Okay, here we are. I think last time I checked, it looked like we had a quorum, and Jordana affirms that's correct. This is a called order of the special board meeting of health meeting, special board of health meeting, January 13th. I want to, I guess we're going to go right into review of the agenda. Any questions, additions, or changes to the agenda, Jordana?
There have been just a couple. I've updated it. The presentation on OWTS is actually being given by Brian Dougherty. We've added a quick presentation about vaccination and testing by Carly Senst will be jumping on later to do that. And we've also added a link to the agenda so that the public will have access to view any of the public comments that have been submitted.
Great, and we do have, as you probably have all noticed, we do have several public comments, a lot of worthy of digging into and reviewing. So with that, I think, let's see, I'm got a review of the agenda, but what I need next is an approval of the previous minutes. So I take a motion from Dr. Kurt, seconded by Dr. Linda Vera. Thank you. And all in favor, raise your hand. Okay, it looks like we're good. Thank you. So that's our previous minutes. Now on to the business. The first thing up is on-site wastewater treatment systems regulation revision, and Brian Dougherty, you're on deck.
Yeah, sorry, it's Dougherty, but that's okay. Anyways, I just wanted to just quickly give a brief overview of what OWTS is. The on-site wastewater treatment system. So every house outside of the municipal sewer districts of Aspen and Snowmass and Redstone and Basalt and a few others is served by their own wastewater treatment system. And there's about 3,000 in Picken County currently. And these regulations are part of public health because they protect our drinking water. Basically, the water that we use is treated and put back into the groundwater where we can reuse it. And bacteria in the soil and in the tanks are able to treat that effluent and make it safe for human consumption at a later date. And there's also a bunch of reasons why we can be very concerned with problems with wastewater if they're not treated properly. Nitrates can cause blue baby syndrome. It's a devastating disease that caused by nitrates that are produced from wastewater. So I just want to, if we want to switch to the next slide, I can briefly show what a septic system, how it works. So you can see here, we have our groundwater well at the top corner. And then our house, so that's where our house's water is coming from. And then as the water is used, it goes into this treatment tank. And in this tank, it allows for some separation of the oils and grease kind of floating to the top and the heavier things to sink to the bottom. And that clearer effluent in the center will be able to move on to the next chamber of the tank and separate more of those scum layers and sludge layers to be able to have a clearer effluent that goes out into your drain field. There's also anaerobic bacteria that work in this tank to be able to digest the microbes and viruses and other things that could be dangerous to human health in these tanks as an anaerobic system. And then as it gets out into the field, the microbes in the soil also treat the effluent in an aerobic type bacteria. And scientific studies have shown that about 4 feet of soil is able to completely treat that effluent to have no risk in the to groundwater below it as that works its way back down. If there are problems with the soil or groundwater is much closer to the surface, we do have a lot of areas like that in the county. There are ways to put advanced treatment is what it's called. And it cleans that effluent much better and has a much lower nutrient load when it goes out into the soils. So it'll be able to be treated quicker with less soil. That's basically how this works. So your tank's always full and separating, and that's how it works. Anyways, we had to make a couple clarifications to our regulations that we can switch to the next slide, that we put out in 2018 that just make things more clear for our customers and makes it easier for everybody. So basically, we did not previously have permits for pump replacements and piping repairs. And we have some concerns that maybe the wrong pump would be installed and not be able to make that system function properly. And we just want to make sure that these things are being done properly. So permitting these instead of just letting them happen seem to be important. We changed one of our setback requirements for only agricultural ditches. It was 100 feet, and we aligned that back with the state current setbacks of 50 feet because the risk of contamination is low. They're not being used 365 days a year. And this is the standard across the state. So it made sense to us. Operating permits, and those would be a permit that shows that you are providing maintenance to your advanced treatment system. And most of these advanced treatment systems, like I said, are in areas with poor soils or high groundwater or reasons why they need to be there. And they need to be maintained properly or else they don't work right. And that's a risk to contaminating our groundwater. So this is a new program that we just started finally this year, but we had some cleanup in this section of the regulations that originally our contract, that the permit was going to last 2 years. We changed that to make it end at the maintenance contract ending, which just makes things more clear. Like if you had a 5-year contract for your septic system, your permit would be good for 5 years, because that's what we're looking for this is proof of maintenance that is required for these systems. And they usually are once or twice a year, depending on the type of system for that maintenance. The use permit program. So there's 2 things that we do with the use permit program. Anytime a house sells that's on a septic system, that septic system needs to be inspected to ensure that it's working properly. And as a result of that inspection, you receive a use permit. Originally, the state had made those expirations of 6 months, and they changed that in the last 3 years. And it just makes more sense. Sometimes houses don't sell within 6 months, and it creates a lot of confusion. And it doesn't cause a risk to public health. And then the other reason that we have these use permits is for remodels and additions. And we just clarified how this would, when you need to do this, because that was kind of ambiguous and previously in the regulations. So currently, it was an understanding that if the project valuation was $30,000 or more, they would require that. But we ran into some weird issues where people would be changing out fixtures and cabinets and things, and it would be more than $30,000 valuation. And that doesn't really make sense for what we're trying to do. So we're asking for this when we are doing square footage additions to a home or significant structural changes to the interior home. So like knocking down walls, creating new rooms, those sorts of types of work is when we want to make sure that that septic system is working properly and is the proper size for whatever addition or changes they're making to the home is. So this is all of the changes that we made to our regulations. Very, very minimal. So basically the next steps is that the Board of Health has the authority under statute to make a motion to approve and adopt these regulation changes.
Okay, thanks, Brian. I have some questions. I'm wondering if the board might also, does anyone want to throw a question? Any concerns or questions about this? I don't see any hands leaping up. I'd love to know, one, I wasn't sure if you're talking about every type of septic system, or are you just talking about the more sophisticated ones that use pumps and have technology?
So the operating permit is only for those sophisticated type systems that you need to provide that proof of maintenance and receive that permit showing that that maintenance is being provided.
Okay.
So that would be with these aeration systems, other treatments that, yeah, they're specialized processes that are approved by the state. And part of those requirements of being allowed to put those types of systems in is having this maintenance.
Got it. Now, the next question is, how are we aligned with state regulations here? Are these state rules that we are complying with, or are these our own rules?
So yeah, the state has regulation 43, and our regulations are modeled after the state's. Just like with any other regulation, we can be the same as the state, or we can be more strict at the county level, but we can't be less strict. So there are a few differences between the county regulations and the state regulations, but they do follow each other very closely.
Okay, if you wouldn't mind, if we can briefly look at the differences with the state reg, I think that's an important thing to distinguish.
So we have a couple opt-ins. So these two types of permits that I just mentioned, the use permit and operating permits, are not required to be done by the county. The operating permits, if we were to not do those and show that proof of maintenance, we would not be allowed to have people install those advanced treatment systems to receive those reduced setbacks, which would be a major impact on our community. So we've opted into those two programs. Some of the other differences are some setback difference. So like for rivers, the state minimum is 50 feet, and we aligned with the county's land use code to be 100 feet. So a lot of things like that.
Got it. Great. Thank you. Thanks for that. I don't see any other questions here. Let's keep moving. Is that it? Do we need a motion for an approval? What?
Dr. Kurt.
Tom's got a question.
Dr. Kurt?
The approximate cost of putting in a new system if you're adding a bedroom to a rural house?
I don't have a good answer for that. I don't really look at the quotes that we see for these permits. I know it can range from 20,000 to 70 or more, depending on the types of technology that are required.
Thank you.
But Brian, this is Kurt. That cost is for an entire new system. Is that correct? Not just an addition? Right.
Got it. Okay. Now, the last thing is, how will people know whether or not they have what, I guess people would know which type of system they have, but
yeah.
How do we make sure they don't fall
completed
afoul?
that outreach and sent letters over the summer and through the fall to make sure that all of the homeowners with these types of systems were notified that they're required to do this. Because it's the first time around, we've had a bit of issues just getting in touch with every single person, but we're definitely making progress, and we have more than 50% of our systems permitted now with this new operating permit that we just started.
Okay, I'm ready to accept a motion that we approve the on-site wastewater code amendments. We can discuss it more after the motion if we need to, but I'm looking for motions.
I'll step forward and make the motion.
Dr. Kurt, thank you. I need a second. Tori beat you, Krista, but just by a little bit. Okay, all in favor, give us a right hand. Anybody opposed? Okay, anybody uncertain? All right, I guess that's it. It passes. Thank you.
Great, thanks very much.
Thanks, Brian. All right, we're going to keep moving here. Strategic planning process review with Jordana. You're up.
Thanks, Greg. So if we go to the next slide, I just wanted to remind the board what we walked through last time. Of the last meeting, we introduced the strategic planning process, and part of that was for, during this meeting, to review our Colorado Health Assessment and Planning System, which Suzuho will be giving today. Also to go over Board of Health powers and duties. We've got Michelle Shimamura here to be able to present that to us from CDPHE. And that just to cue in that this presentation on board and staff relationship we're going to push to our next Board of Health meeting. The agenda ended up filling up, so we'll bring that at a later date. So as we move forward, we will continue to introduce the strategic planning process to staff this month, work internally on some internal department priorities, and then come back at our next Board of Health meeting to determine some additional Board of Health priorities and actions. So just a quick reminder to everyone there. And next, I guess I'll pause if there's any questions, and if not, I think that's all I've got.
I don't see any questions. Of course, anybody chime in if you have one and we're not recognizing you. It's just because we don't see you. So is that it, Jordana? Sorry, are you pulling something up?
That's it. The next slide is just the presentation on our CHAPS process, which Suzuho is going to be walking us through.
Great, thanks.
All right, hi everyone. Good to see you in 2022. So as Jordana mentioned, I'll be talking through our CHAPS process. If we can click to the next slide, please. Just as a friendly reminder, or I'll start with a little bit of a framework that the state uses around our CHAPS process, and then remind everyone of what we went through in the 2017 to 2022 5-year planning period, and then share our proposal, very high-level proposal for what we have planned for this next 5-year period as well. But as a reminder, with the 2008 passage of the Colorado Public Health Act, every local public health agency is required to abide by these core public health services. So the top part that you'll see in the box lists out our foundational capabilities, and then the bottom part is our foundational services. So if we can all dig way deep in our brains to the Board of Health retreat we had pre-COVID in that January month before the pandemic, we kind of went through these and had the board prioritize the different areas that we wanted to focus on with our foundational services. And today I'm just going to talk about the first part of the foundational capabilities. That assessment and planning part is one of the core requirements. We have a 5-year planning cycle. And so the first part is going to start with this assessment and planning. If we can go to the next slide, please. That really helps us understand what's going on in our community and how we can best serve our community as a local public health agency. Starting with analyzing local, regional, and state data sources. This could come from state level data that's collected. There's a lot of different state and federal surveys that are conducted by CDPHE or CDC that we can pull data from. There's also our local community surveys, our mental health needs assessment that was done at the end of last year, things like that, where we'll be pulling in some information from our community. Creating the community health assessment is, again, this starting point of the 5-year planning cycle, where we hear from the community about what the current needs are and what the gaps in services are to ensure that our community has all of the supports and resources needed to be able to thrive here in Pickens County. And then using that feedback to help develop our 5-year public health improvement plan. So that's the general process. If we can go to the next slide, just a reminder of what was discussed in the previous planning cycle. So there was a partnership between Pickens County Public Health, Garfield County Public Health, and Eagle County. And so we really created this regional plan in partnership with some support from the School of Public Health, which we're hoping to do this year as well. Some of the primary data that was collected was done through nominal group techniques. So really getting feedback from the community, having them help us prioritize different topic areas, an environmental survey that looked at different needs here in the community, and then integration and prioritization process that brought the whole region together to think about what are the common needs across the Roaring Fork Valley, and then also specifically to Pickens County. So we'll go over those in a little bit too. And then secondary data, again, this could be census data like demographic information around income, education, et cetera. Things related to housing, water, just what's going on in our environment, knowing that environmental health is a part of public health. And then health status. So what are the health indicators and outcomes across our population to really understand how healthy our community is as a whole, as well as within different subpopulations where we know health inequities have historically existed. Next slide, please. So this lists out the different priorities that were created for the current public health improvement plan period that we're in. So regionally for the Roaring Fork Valley, that Tri-County region, mental health, suicide prevention, and substance use were all prioritized as kind of the top issue for us to work on. Second was access to healthcare, then housing and water quality. And we really try to focus in on those top two, thinking about what's reasonable and realistic for us to be able to do in a 5-year period. And then smaller efforts around the housing and water quality as well. And then locally, specific to Pitkin County, I won't read through all of them, but those are the different priorities. So definitely some overlap between the regional and local priorities, but we also found some ways to ensure that Pitkin County residents' voices were heard and addressed with our local efforts as well. Specifically, as you all know, climate change was big, not just for public health, but across the county. So there's various efforts there as well. Go to the next slide, please. All right, so in regards to the overall CHOPS process, these are the 8 steps that have been outlined by the state as an initiative to try and standardize this process across all of the counties and local public health agencies here in Colorado. So these are the steps that we are hoping to work off of. It is a guide for us. So there are things that we can definitely review and think about what's going to resonate most with our community or what will work best for our community and adapt it to fit our needs as well. But overall, wanted to share that these are the various steps that are a part of the CHOPS process. This is typically a 12 to 18 month process. So we'll be looking at it in that regard as well. So starting now, really, we've already started a few steps, and then going into spring of 2023 is the timeline. Next slide, please. So here are some more details around that timeline. So right now, as many of you know, we did receive 2 grants from CDPHE. So we're very fortunate to be awarded the preventative block grant again. So these funds were used last year with the award that we received last year to support a lot of our Hispanic Latinx Spanish outreach and engagement around COVID. And then this year we're able to use this towards our planning process as well. There's also the ARPA funds, the American Rescue Plan Act funds for a 3-year cycle that based on a Senate bill that was passed last year, there's $11 million being appropriated to CDPHE and local public health agencies. So our department's getting about 60,000 of that. So those 2 grants have been applied for, and we have contracts in place with CDPHE to help support the planning analyst position, which was approved by the BOCC in December. And we actually have it posted now. Sorry, I did not update this slide. I just realized, but it closes January 30th. So it's posted now. If any of you know anyone who would be a good fit for our department to help us with this effort, please feel free to share that job posting with them. And then in January now, this month, we are going to start our work with the Colorado School of Public Health. So they have a community health assessment course where it's designed to offer students in a master's in public health program the opportunity to gain some fieldwork experience. And so usually there's a student group anywhere from around 7 to 12 students who get assigned to, well, maybe smaller, 5 to 10 students who get assigned to partner with different agencies across the state. There's usually 2 or 3 projects that are selected per semester, and we were fortunate to be selected as one for this year. So we'll be working with some MPH grad students to help us out with this process. I'll be presenting to them on February 4th, and then hopefully getting paired up with those students shortly thereafter. And then in the spring, that cohort of students will really be helping us to research different equity strategies that we can implement into this process, reaching out to CDPHE to get some of that data that they have available, in addition to our local research that we'll be doing, collecting some secondary data to start looking at what's generally the landscape here in Pitkin County and our community's health. And then also collecting some primary data through focus groups, interviews, community surveys, things like that. They will then generate a report of the top health concerns or the various health concerns that were identified through that community health assessment. And then in the summer, the planning analyst will help us go through a capacity assessment to understand, based on the needs we've heard from the community, what can we as a staff really achieve, or what what our capacity is to be able to address some of those needs, what partnerships need to be built, or what additional staff growth we need to invest in to be able to best support our community and growing in those identified need areas. And then in the fall, we'll be working with the School of Public Health again to really draft out that improvement plan. So that's the 5-year community kind of strategic plan around how we will improve our community's public health. We'll be sure to include the Board of Health along the way, just to share updates with you all and share back the results from our needs assessment and what priorities are being identified. We also encourage you all as individuals to participate as community members in the various processes as well. But our goal is that by the kind of winter of end of this year to early next year to have that finalized plan to be able to bring back to you all for final approval and then submission to the state. And then last, I think the next slide is the last one. Just a request for that board involvement. Again, we'll be creating an advisory board to help guide this work to make sure that it is community driven. So if there are any of you who are interested in being on that advisory board, if you can reach out to me, we'll start building out that group over the next few weeks here, depending on the timeline of the planning analyst being hired as well. But it'll be a collective of community voices, as well as partners, key partner organizations that will be a part of this. Other things that we request is that you're able to participate in some of those activities. I know some of you have shared that you participated in the activities last time and the focus groups and prioritization processes. So would love to see that again this time around, helping us recruit individuals to get more community voices involved in these areas, and then just providing input on the different stages of this process that I have outlined here, and then final approval by March of 2023. That's it. I'll open it up to questions.
Tori, is that a question? Okay, this is how you're waving. All right, looking around here, I'm going to go back to the, I don't see any questions. No action items here. That's just an update, correct? Correct. Okay. All right. We're going to keep moving then. Thank you, Suzuho. That was fast. My gosh, you cranked through that. Board of Health powers and duties. Today we have Michelle Shimomura with us. Welcome, Michelle. And I'm just going to hand it off to you.
That sounds great. So I am Michelle Shimomura, and I'm with CDPHE in the Office of Public Health Practice Planning and Local Partnerships. I'm really happy to be here today and to talk with you all. I have some slides I'll run through, but if there's any questions, feel free to stop me in the middle of the presentation or at the end. I'm happy to just have this also be a conversation. So I'll talk kind of broadly about just public health, taking all the way back to the very beginning, just talk about public health structure a little bit, put Colorado a little bit in context of the nation, and then talk about the local boards of health and just the public health structure in Colorado and their role and duties. And many of you, I think most of the local boards of health probably received an email from me as well. So as part of legislation last year, local board of health members have to take an annual training. So much of what I have and I'm going to go through is also in this annual training, which is an on-demand format. It's online. It's a public health orientation, which is mostly what I'm going through. And then it also has the local board of health members' responsibility in emergencies. So those are two components of the legislation that got passed last year. That's gone into effect January 1st of this year. It's an annual training, so we're looking at, and I'm definitely open to feedback of what, especially after you take the training, what you would like to see in future years for training too. Since it's an annual training, I don't want to make it where it's the same training each year, but we could do a deeper dive, go into different subjects in year 2, 3, and 4. I'm thinking of potentially doing a 4-year cycle of this annual training. So we touch upon topics and areas that are interest of you as well. So just putting that out there either as we go or after you take that online training. If there's something you really want to know more about or you would like us to create more content for, let me know, because we are actively starting to think about year 2, 3, and 4 of that training. All right. Go ahead to the next slide. Actually, one more slide. All right, so we'll talk, like I said, I'll talk a little bit about the structure of what public health looks like. And good, yeah. So the overview, we'll talk a little bit of national public health structure, the history. Suzuo mentioned the Public Health Act 2008, and that put into a lot of things like the planning cycle and the CHAPS process. So we'll talk a bit about the influence of that legislation. Public health structure of Colorado. I'll briefly talk about the State Board of Health, local boards of health, public health, the executive director, and then some other roles that are also in the statutes in rules as well for what local public health looks like. And then I have some slides just on resources as well and links. I, wherever possible, try to lead with other things that are available beyond this training for people as well. All right, next slide. All right, so putting just Colorado into context nationally, this is a map of just what public health, local public health governance looks like across the nation. It's different state by state of how public health is organized, and it's much like the difference in other governance structures nationally as well. But in the West and North, the majority of the governance structures are local public health agencies, are units of local government, and this is Colorado's structure as well. But I just want to have it noted of which where states are very similar, but then some states operate very differently as well. Some LPHAs are a part of the state in other states. Some have a shared kind of local state governance or kind of a mixed model as well. But as you know, local public health agencies in Colorado are units of local government. Next slide. So nationally, 61% of local public health agencies serve jurisdictions of 50,000 or less. These agencies serve 9% of the total population. And then only 6% of agencies are considered large, with jurisdictional populations of over 500,000 people. And then 52% of our nation's residents are served by these large agencies. So I think this slide is important too, to give in the context of local public health in the United States, and very similar trends hold true in Colorado, where the majority of local public health agencies serve smaller populations, and then very few are in the metro areas and serve larger populations. Next slide. And certainly you'll have the slides afterwards, and this is also a little bit in the training too, but also nationally looking at the different sorts of services and programs that local public health agencies provide. Not every local public health agency provides every single service. Some concentrate, depending on what their needs of their community are, some concentrate on more areas of services and programs than others. And so it definitely varies. But this is just a percentage of LPHAs and what their different kinds of clinical programs that they provide in this past year. And these are slides that are, like I said, nationally as well. So Colorado follows very similar patterns, but it's not the exact same percentage. Clinically, lots of local public health agencies provide services in immunizations, screenings for disease and conditions, treatments for communicable diseases, maternal child health services, and then other clinical services are sometimes offered too, like home health care, oral health, behavioral mental health, substance abuse, and things of that nature. And next slide. Now that I had one more slide in there, but perhaps not. So I did have one more slide I meant to put into. There was also lots of programs and non-clinical services as well. I may have accidentally duplicated or taken that one out, but some population-based programs are a really important part of local public health too. So epidemiology and surveillance type programs, population-based primary prevention, so tobacco prevention, nutrition education, chronic disease programs, physical activity. And then there's regulation arm of public health as well. So regulation, inspection, and or licensing. So food establishment, inspections, child care, schools, septic systems, things of that nature. Other environmental health services, oftentimes food service education, vector control, indoor air quality. So some of these are outside of the clinical setting. They're really the population and looking at more upstream prevention programs that impact a whole community. All right, now next slide. All right, so we'll jump right into the public health structure in Colorado. And I kind of organize this from the state level, then coming down and looking down into the local public health agency level. I think it's sometimes there's a perception that the local structure mirrors the state structure, and that's not necessarily the case. There are some really important differences as well. Next slide. So the State Board of Health, I'm sure many people who have been around definitely know what the State Board of Health looks like and the structure, but in case anyone's new, the Colorado State Board of Health is a 9-member State Board of Health, and it was established back in 1877 by an act of Colorado's first General Assembly. And the State Board of Health members are appointed to staggered 4-year terms by the governor. One member is appointed from each of Colorado's 7 congressional districts, and 2 members are from the state at large. 1 board member must be a county commissioner, and then no more than 5 members can be from the same political party. Next slide. And the State Board of Health has several charges that are under their purview. So they can adopt and revise standards, rules, and regs to administer a public health law. They determine general policies and enforcing laws. They advise the CDPHE executive director. So they're really in an advisory capacity to the executive director. They approve different grants to local public health agencies and community-based organizations. And then some of the rules that are under their purview, state statute, sets the statutes, and then they're promulgated into rules. And from my office's perspective, and some of the things that we help local public health agencies with is there's rules that the board sets regarding the minimum qualifications for executive directors or directors of local public health agencies. So when there is a new executive director, a minimum qualifications form gets sent to my agency. And we really use that to say, what kind of experience level, what kind of education level does the executive director has? And then how can we best support that executive director to get up to speed, and what kind of learning pathway do we need to create, or what kind of technical assistance support can we provide? So that executive director can be at their best for the communities which they serve. There's also core, which is the core public health services, and that is what the same slide that Suzu went through as well, with the foundational services and foundational capabilities. There's a funding formula rule as well, and then evaluation criteria for local public health agency plans. And then the State Board of Health also approves the Colorado's Public Health Improvement Plan as well. Next slide. And I just put this out as there's other rulemaking bodies within the state as well. So there's other type 1 boards and commissions, such as the Air Quality Control Commission, Solid and Hazardous Waste Commission, Water Quality Control Commission. So they are also able to set rules, which then guides the requirements for local public health agencies and the state as well. And then type 2 boards are more oftentimes in an advisory capacity. They're not necessarily the rulemaking kind of boards and commissions. And next slide. So getting down to the local public health agency structure, local public health agencies consist of the local boards of health, and then a director is appointed by the local board of health. Every LPHA has to also have a medical officer if the director is not a physician acting in that capacity. and relevant personnel to carry out duties such as environmental health specialist, public health nurse, health educator, epidemiologist, health planner. There's a variety of different roles and positions. It looks very different from local public health agency, the local public health agency in Colorado, but many of them have a core set of staff to carry out the work. Next slide. All right, so just what the structure and the rules and for what a local board of health looks like. Within county local public health agencies, each county board of health consists of at least 5 members. The terms are staggered terms. Members must reside within the county, and then in counties with populations that are less than 100,000, 3-member board may be appointed. And there's some nuance too of that. If the board was in establishment at the start of the Public Health Act of 2008, then the 3-member board can be the board, also the county commissioners. If it's after that, then it needs to be a 5-member board. And there are several district local public health agencies as well, and their boards look a little different. They also consist of 5 members, and they have to have at least 1 member from each county, and they all have to be residents of the district. And then for all boards, except for the boards that are also the same as the county commissioners, no boards, professional group, or government entity can constitute a majority of the board. And next slide. All right, and just some of the rules around local board of health, local boards of health. The meetings have to occur for local boards of health every 3 months. Special meetings may be called by the president, the local public health director, or a majority with a 3 days notice unless it's an emergency, and then you have 24-hour notice. Can adopt bylaws, majority is a quorum. Members can't be compensated except for reimbursed for expenses such as travel and food. Next slide. And some of the duties of the local board of health is to select the local public health director, and often in conjunction with the local public health director to employ, contract, or secure a medical officer. It's a duty of the local board of health, but oftentimes the public health director assists in what that looks like in getting that medical officer. Holding meetings every 3 months. The director cannot be a local board of health member or a board member, but they can be the secretary or can help take notes as far as facilitating the meetings with local boards of health as well. But that's important as well, that the executive director cannot be a board member. Hold hearings, issue orders, adopt rules, closing schools, businesses, that kind of thing. And then local boards of health also approve the 5-year local public health plan and submit that plan to the state board of health. It's a good recommended practice to have other expertise on local boards of health, or at least advising local boards of health as well. So the National Association of Local Boards of Health recommends that boards reflect the diversity of the community in which they serve. So diversity from potentially even having community members on the board, or at least experience from different segments of the community. And then having specialized expertise too, such as mental health, environmental health, health promotion, education, community advocacy, or like I said, community residents. And now we'll move on to the local public health agency executive director. They are responsible for administering and enforcing public health laws. They exercise all legal powers for things for especially communicable disease control. They act as the local registrar for vital statistics, direct resources to carry out the public health improvement plan, so the FIP, and the community health assessment. Issue orders during a public health emergency, such as water boiling, isolation, evacuation. And then they have all the local public health agency staffing decisions. So I won't go into this too much, but this is when I mentioned earlier, the local boards of health And when they select an executive director, they fill out a minimum qualifications form and then submit that to my office, OPHP. And these are just the minimum qualifications for a public health executive director. If an executive director doesn't meet the minimum qualifications, they can also get a waiver or get a substitution for education or experience as well. And executive directors can be physician candidates, in which there's kind of one track and one set of minimum qualifications, or non-physician candidates as well. And you can go ahead into the next slide. Local public health agencies, by the Public Health Act of 2008, also have to have a treasurer. A single county local public health agencies has a treasurer that serves as a single county local public health agency may have the county treasurer serve as the agency treasurer. There's some different rules if you're in a district local public health agency of how to select that treasurer. The treasurer creates a public health fund to which shall be credited any monies appropriated from the county general fund to public health, any monies received from the state or federal appropriations, or any other gift grants fees for local public health purposes. Funds that are credited to the account must be expended only for public health, and then claims against it must be certified by the public health director and the president of the Board of Health. And then on or before September 1st of each year, the public health director, along with the local Board of Health, shall estimate the cost of maintaining the public health agency for the next fiscal year. All right, next slide. And then there's also within state statute to involve a county attorney anytime, for a legal order, rule, hearing, or action area necessary. It's just verifying legal powers, advise the development of legal documents such as orders, and then they can bring civil or criminal action as well. And then just some other considerations, like any other board, this is not public health specific, considerations of just open meeting laws, which is part of the Colorado Sunshine Law, and then the Colorado Open Records Act as well. Obviously local boards of health are not exempt from these two as well. This is just part of the Colorado Revised Statutes. I have in there, it's Title 25, it's Article 1 Administration, and then Part 5 is the Public Health. I have links to different relevant statutes and some rules as well that we can send out, and we'll have those available on the public health orientation training that's online that all local Board of Health members have to take. So next slide. And then these are some links. If the slides are provided to you afterwards, you can just go right to the state statutes and the rules as well. Next slide. And then these are just some links for other resources as well. Oftentimes in this presentation, if I am talking a little bit larger or have larger scope, or have a little bit more time, I can talk some about public health data as well. So these are some different data sources that are available to look at health in communities and just some of the health outcomes and where different communities might have different needs. And that is all I have. So I thought I'd put in a contact slide too, but Jordana or Suzuho will definitely have my contact information too.
Thank you, Michelle. Appreciate that. And very, very brief and fact-filled. I thought I saw something about history in there, and I was just going to say, if anybody has the chance on their own time to look up the history of Colorado's public health, the woman who was appointed by the governor, the first public health director, is a fascinating person, and there was a great profile of her, I think, in the Colorado Sun a year or so ago. And I couldn't find it. I'll share it if I do. But anyway, it's interesting stuff.
In the online training, I'm not sure if anyone has gone through that online training yet. Oh, Krista has. All right. Yeah, I took right from there was a great 20-minute kind of history of public health video that was created a few years ago. And we used that because exactly. The history of public health is pretty interesting.
Right. Thank you. We'll look for it. Okay, we're going to keep moving here unless we have questions or anything else from anyone else here. But thank you so much. We all appreciate you taking the time, and we know who you are now, and we're going to see you again, I'm sure.
Yep, definitely. Thank you.
Thank you. Okay, we're going to Josh and Jordana. Welcome.
Right. Next slide. Okay, I just have a few slides to kind of give an update on what's going on locally, and then just a few other pieces connected to this Omicron surge. So locally, right, we've seen more cases than we ever had reported throughout the pandemic, and that is a trend that has held true with many other jurisdictions and states and countries as well. They're just seeing more cases now with this more infectious variant. So that graph on the top left is showing all the daily cases reported throughout the pandemic in blue, and then our instances there in the gold. So we have been averaging between a 3,000 and 4,000 incidence rate per 100K. So again, that's about double where we were last year. The graph on the right is comparing year over year. So the gold is 2020, green 2021, the blue is 2022. So you can see our incidence this year is about twice what it was last year. Our 7-day instance as of the 10th was at 3367, and I'm reporting on the 10th because there has been a lag due to reporting delays from the state. So we're still getting in results from this past week or so. So we're estimating our instance to be around 3367, but it's likely an undercount. It's probably a little bit higher than that. Our positivity rate has really been hovering above 30% for a while now, and been around 40 to 41% for the past several days. There is some indication that the positivity rate might be cresting a bit or peaking, and usually positivity rate lags our incidence by several days. So there is some potential good news there. We currently have 2 residents hospitalized, but one is hospitalization from early December, who was a Delta variant infection, and then another one who was hospitalized, but COVID was a secondary diagnosis, meaning they were hospitalized for something else and then so happened to test positive for COVID. Our last resident death due to COVID was on 12/5. And just wanted to also make a note that most at-home antigen tests do not get reported, and so they're not included in our incidence rate. So if all of those were to be included, our incidence would likely be higher than what we're reporting as well. But that's true for basically all jurisdictions. They're not really getting a full grasp of how many positive antigen or at-home antigen tests are out there. So everyone's probably being undercounted by quite a bit if those individuals are not getting or if those individuals are not reporting those at-home antigen tests. We are trying to report some of those in our local incidents, but CDPHE and CDC are not including those in their incidence rates. If you look at their websites, there's going to be these differences in our incidents for several reasons, but that's partially the reason. Next slide. So did want to show what our case to hospitalization correlation looks like. So this would be essentially the proportion of individuals who test positive, who then require hospitalization. So on the graph on the left, this is throughout the entire pandemic. The blue is a case count over a 28-day period. So at any point on the graph, that's how many cases we had in the 28 days prior. And then the same idea for hospitalizations in the gold. That's the number of hospitalizations we had in the 28 days preceding that date. And again, we have to use a 28-day period because we have a low sample size being a small county. You can see there's a really clear correlation there for the most part. Once we get to the Delta wave, which is between July and November of last year, we do see the rate of hospitalizations increase a little bit to a level that was higher than what our case counts are being reported as. But then as we've reached this Omicron wave, you can see that the gold line is not trending up with the blue line. So we are seeing this reduction in the proportion of individuals that are testing positive who require hospitalization. The graph on the right really starts to hone in on that a little bit more. So this is the red line is the proportion of all of our cases who have required some length of hospital stay, whether it was 1 day or 10 days, they're all included in that count. So you can see during the Delta wave, which is really the left-hand side of the graph through about the middle of the graph, we had anywhere from about 1 to 4% of individuals requiring hospitalization. And then once the Omicron wave really began, indicated there with the vertical line, you can see the proportion of cases requiring hospitalizations has decreased fairly substantially. So right now, our current case to hospitalization proportion is at 0.32%. In other words, of all the cases, 0.32% have required hospitalization. Some of those individuals, COVID is a secondary diagnosis. So they're hospitalized for something else and then tested positive for COVID as well. And that is in comparison to the Delta wave case to hospitalization proportion of 2.47%. So it's about a 7-fold decrease at this point. But again, you know, we're still in the middle of the surge, so that data will change. But as of the 10th, that is where our data stood. We have had 6 hospitalizations since the beginning of December among county residents. But again, really because of the sheer number of cases we've had, that 6 is not as high as it would have otherwise been projected to be had the Omicron variant been as infectious, or sorry, been as severe as prior variants. Next slide. Did want to touch really briefly on this. There's been a lot of news articles written about 0 to 4-year-olds requiring hospitalization more so than other age groups, and did wanted to kind of clear that up a little bit. So there is a higher number of 0 to 4-year-olds who are requiring hospitalization, but that is a function of how infectious the Omicron variant is. So we're seeing more cases of Omicron, you know, more cases in this wave than in any previous wave. And so as a byproduct, we're just seeing a higher number of 0 to 4-year-olds requiring hospitalization. So the graph on the left, the case count is in that light blue, and then the hospitalization data is in that darker blue. And so you can see they kind of both trend up together. But on the right-hand side, that gold line, that is the proportion of all 0 to 4-year-olds who test positive who need to be hospitalized. So you can see actually during the Omicron wave, it's actually decreased. So we're actually seeing a slight lowering of the rate of 0 to 4-year-olds who require hospitalization. So, you know, again, with how infectious Omicron is, we're going to have more people who are going to go into the hospital and require hospitalization, but it doesn't mean that we're seeing a higher rate of individuals who require hospitalization. So just wanted to touch on that real quick. And both of these graphs came straight from the CDC. And the way that they're reporting the data, they report it by population. So it does actually look somewhat misleading when you look at the graph that's on the CDC's website. But when you actually dig into it, the actual proportion of 0 to 4-year-olds who require hospitalization has actually declined a bit during the Omicron wave. Next slide. There were 2 studies recently, as well as an FDA memo that have come out that have cited that there might be reduced sensitivity with antigen testing as it pertains to detecting people that are infected with the Omicron variant. And so in other words, what this means is that they're seeing a higher false negative rate among people who are using an antigen test who have the Omicron variant. So some people are, you know, seeking the antigen test, whether it's an at-home antigen or commercially, and they're getting negative results despite having symptoms. And part of that is due to this decreased sensitivity among the antigen tests to be able to detect people that have the Omicron variant. So the study on the left-hand side, what this graph is showing you is on day 0, all of those shapes, the triangles and the squares, those are individuals that tested positive on PCR. The red means that they were negative on antigen. So each individual in this study, and it was a small study, only 30 people were in this, each person that tested positive with PCR was negative on an antigen test. On day 1, after the initial positive PCR, you can see still everyone was negative on an antigen. And then by day 2, there was a few positives. Most people were still negative. And then by day 3, that's when you started to get more positive. So what this study was showing essentially is that there were several people who had symptoms or were likely contagious and were testing negative on an antigen, but positive on a PCR. What this study also had that 4 of the 30 individuals in that study, they spread the virus to other people just while they had a negative antigen test. So, you know, had the antigen been positive, they may have stayed home, but because it was negative, they assumed it was likely not COVID and then ended up spreading the virus to other people. That is what that one study found. Again, small sample size, so it's hard to extrapolate too much, but there does appear to, you know, their study really does support the FDA statement that there might be reduced sensitivity here. And then the other study I just wanted to mention on the right-hand side also looked at the same idea with the Omicron surge and found actually that antigen tests were doing a lot better at detecting individuals that had Omicron variant. The problem with their study is that they used a really large time frame. So they said anybody that was symptomatic between day 0 and 7, that's what that graph is showing you there. And so they didn't really differentiate between how many positives were on day 0 or day 1, as the study on the left-hand side did, versus how many were positive on day 6 and 7. So there could be a difference there in how they're reporting their results, but regardless, there does appear to be this reduced sensitivity. So I just wanted to mention this as, we anecdotally are seeing this locally as well. People are symptomatic, they were exposed, they're using an antigen test on day 0, 1, or 2, they're getting negative results. And so we're really pushing people to get a PCR test in order to confirm that they truly don't have COVID. So this is something that we're really trying to make a note of locally to ensure that we're getting catching as many positives as possible by pushing them to test with PCR and not solely antigen. Again, the graph on the left, the study on the left, shows that antigens are doing a lot better later on in infection. So using antigens later on during the course of infection with Omicron does appear, they do appear to have really high sensitivity, but early on is where the issue is. Slide. So then lastly, I just wanted to touch on this real quick. So we've talked a lot about in previous meetings, masks being really good at preventing having efficacy at preventing infection. Obviously, with Omicron, we're seeing an increased spread among individuals that are masked. Despite the two wearing masks, we are seeing more spread and more infection. But do want to comment on several studies here that have found that even though individuals might be testing positive when they are exposed despite wearing a mask, there is likely a significant decrease in severity of illness, and it's actually decreasing hospitalizations and very likely decreasing the number of deaths that are occurring among people that are wearing masks. The basic immunology here is that if you're both wearing masks and you sneeze through the mask, then the amount of virus that's getting through the mask to the other individual is going to be less than had you not been wearing a mask. So the person that's exposed, the person that has COVID, will actually be breathing in or taking in less viral particles, and therefore they have a lower viral load. And so their body is able to respond a lot more quickly than if they were to get a larger dose of virus due to not wearing a mask. And so you kind of give your body the ability to be able to respond a lot more quickly. And that was what Dr. Gary here, this professor of microbiology and immunology, had cited in this one study that he had done. Is really that sort of simple explanation there for just how viral infection occurs and then how our body actually tries to respond to it. Obviously a lot more complex, but that's sort of the simple explanation for it. Just want to highlight the last two studies on here in particular. One that was done in 2021. They found that moderately efficacious masks will allow lower exposure viral load will lower exposure viral load tenfold among people who get infected despite wearing a mask. So in other words, people that are both wearing masks, their viral load will likely be approximately 10 times lower than had they not been wearing a mask. And this would actually potentially limit infection severity. And then the second study found that a high initial viral load was an independent predictor of in-hospital mortality. And so this study found that those who had a higher initial viral load had a 5.5 times higher rate of mortality compared to those who had a low viral load. So again, as we look at the data, there's a lot of confounding factors when you look at our local data, hospitalizations, deaths. Truthfully, there's a lot of confounding factors. So it's hard to make a lot of statements about whether or not the masks are what are reducing hospitalizations and death, but they certainly play a role in reducing the severity of outcomes. And so I just wanted to really highlight this as well as clearly people that are being exposed and some virus gets into your body, you're going to develop some symptoms because your body's going to respond. And so it's not uncommon that we would see people who are masked develop some sort of infection and develop some sort of symptoms. But what we're finding is that, and what these studies are finding, are that masks are really reducing the severity of outcomes for people and play a significant role in reducing hospitalizations and deaths. So just wanted to really highlight that as we sort of continue this masking conversation and the importance that masks play in preventing severe outcomes for people. That's my last slide. I think Jordana had one more slide on just kind of epidemiology, and then I think we can both take any questions that anyone has.
Thanks, Josh. Yeah, if we look to the next slide, I wanted to share a modeling slide that the state provided to us yesterday, with their modeling showing potential Omicron peaks. So as we know right now, infection prevalence across the state is the highest that it's been during the pandemic. They're estimating between 5 and 17% of the population in Colorado currently is infectious right now. And then looking at their modeling, what they're showing is that where they're trying to, the black line is the actual observed value. So we see that really fits pretty well with these different models. We've blown by, the blue line would have been what would have happened if Omicron hadn't arrived and shown up. The next line, we've kind of blown by the peak being on January 8th. And we're the best guess that the state is saying is that the peak is going to be sometime between that model in green and red, which would put it somewhere between January 11th and 15th. So this is the latest data from the state. We know that our hospital bed capacity is up around 2,000 beds. So we know that that's really aligning with that red curve up there. So the state is watching this very closely and considering what needs to be done to continue to maintain that bed capacity as we move up. So just to reiterate the message that even though Omicron is tending to be more mild, we still have we're still concerned about hospital capacity across the state, as we know we're going to continue to increase the number of cases. And again, reiterate what this board knows so well, but for any of the public watching, vaccinations and boosters continue to be our best line of defense. Masks, as Josh has illustrated, are also helping to prevent that severity, transmission, and then even severity of illness there. So we'll go to the next slide. And just want to also remind us all of the winter planning triggers and mitigation strategies that the Board of Health approved back in November, where our indoor masking policy continues to be in place as long as we are in the substantial or high transmission. We've got those mitigation strategies that will be in place with us through May, including event safety plans for events with 50 or more people. And Joanna will be sharing some of the event safety plan highlights for Gay Ski Week and the X Games. Our Traveler Responsibility Code is still being messaged, and our business playbook continues to be available to businesses looking to understand how to best and safely navigate COVID precautions. The other mitigation strategies only come into play if our hospital needs to suspend all elective surgeries locally here, or if locally we implement local crisis standards of care. So we've not hit those triggers yet. Next slide. Again, just our mask order. Currently masks being required for anyone 2 or older. And those exemptions are the 100% vaccination verification, students actively playing an instrument, actively eating or drinking, or actively engaged in pool activities. Next slide, I think bumps it over to ABH. So Greg, I don't know if you want to open it for questions first.
Let's go back, and anybody have any things they want to drill down on with Josh? Linda.
Yes, I wanted to ask Josh, I read that cloth is the least effective as far as transmission. Next, surgical masks, and finally, N95s, which I think President Biden is now thinking about giving to all people, but they're difficult to get. So I wanted your confirmation of that, Josh.
Yeah, that's correct, Linda. I would add to that, the CDC released a study last year that found that wearing a cloth mask over a surgical mask can get close to mimicking the effect of an N95. So we also encourage double masking as well if people don't have access to a N95 or a KN95.
Thank you. Is that it, Linda? Dr. Kurt's up next. Okay.
I have a question of Josh about the age group. I've noticed on the COVID-19 site, there are two age groups between age 19 and 30, and the rate seems to be higher in those age groups. Can you track any particular facility, et cetera, that could account for that higher rate in that age group?
Yeah, at this point, Dr. Kurt, we're not able to, since we're not able to reach everyone to determine where they work. We are trying to track outbreaks to the best of our ability, but we're not, able to really sort of pin down the data in that much detail. So don't have any additional information or insight on if there are, specific facilities or organizations that might be contributing to that. Although you're correct that age group, as well as 30 to 40 year old age group, is contributing to the higher incidence rates in the county.
Thank you, Josh.
In addition, I'd like to point out that obesity, diabetes 2, and hypertension are risk factors for hospitalization. And fortunately, Aspen has a relatively low rate of obesity. So we're thankful that we have the skier healthy population here compared to Denver.
That's correct. I just wanted to point out that I've learned that in Italy, they're actually demanding an N95 mask. Wearing a mask in public isn't enough. It has to be that quality filtration. So we're seeing that in other parts of the world. Okay, we're gonna, Patty, you have a question?
Yeah, I have a question. I'm not sure if this is the right place. I believe I saw a letter that came through, or a comment about us closing restaurants, indoor dining in restaurants.
That did come through, Patty, but that's not something that's on the table policy.
Thank you. I just wanted to clarify that so the public was aware. I wasn't sure where that came from, or if it was just something from a year ago that popped up. So thank you, Jordana.
I noticed the same thing and thought and wondered the same thing. Tori?
Yeah, I just wanted to add on to that comment and that question. That seems to be a rumor that had gotten started maybe 4 or 5 days ago that has circulated through the community. So I think the letter writer there, the comment writer there, was just picking up on what they'd heard about. But that is something. Thank you, Patty, for clarifying, because that is something that people were wondering about.
Great. Thank you, Josh and Jordana, for that presentation.
I think Jeannie had a comment, Greg.
Oh, okay. Jeannie,
I did have a comment for N95 mask. They should be masked. You should get a fitting to make sure it works well. And they are quite uncomfortable to wear all day. So everyone just needs to assess their risk in view of Omicron, whether they're elderly or have immunocompromised, and otherwise I think an N95 may be overkill.
Thanks, Jeannie. I think there's a lot of confusion in the public too between an N95 and a KN95. KN95 is readily available and doesn't need to be fit tested. There is a great website that maybe we can link to on some of our on our website to check and see if it's indeed been tested. There are a lot of knockoffs for KN95s. And there is a list that you can go and check if you're the manufacturer. It's actually been proven to be a good quality mask. And then I believe it's the KFN94s that they are truly manufactured in Korea that also have very high filtration.
So can Greg, can I tag onto that? Because of the length of time, I usually have to wear a mask in the office during meetings in our county building. I've found a cloth mask with a filter insert, so I can put a filter in. It's generally the most comfortable, either that or double layering. But I think what Jeannie said is absolutely right. I wish we could enforce, a certain type of mask. And I said, Greg, I think at our meeting yesterday or Tuesday, we're lucky enough to get people to wear a mask these days. So I'm glad to see more and more people wearing them. If we have a hard time enforcing the mask ordinance, we'd really have a hard time enforcing which type of masks. So I think people just need to be aware and alert and know what their options might be.
And Patty, the best protection against having severe disease, of course, is vaccination.
So, I got vaccinated. I got my flu shot. I had COVID last January. I got my booster and I tested positive again for COVID 2 days after my booster. So I'm now like superwoman. I think I have John Peacock, Kitty Lee told me I have one more variant to go.
We're getting her a mask that has high viral load written across the front of it, just in case anybody, gets too close. Thanks, Patty. Was Dr. Kurt, did you have another question? Or are we ready to move on?
Let's move on.
Bill Madsen up next then, sorry.
Yeah, just real quick, Josh, could you just remind us the population number you used for your calculating the incident rate?
Yeah, it's the base census population figure, so 17,767. I believe we're right around there.
Great. And Tori, you had your hand up.
Yeah, I did real quickly. In some of the slides that Jordana just showed, she showed some of the face mask regulations with some exceptions. Here in the city, we've had a couple of conversations with some of our ICE users. Our ICE users were requesting some investigation, discussion, and the opportunity for some of our youth hockey players to be allowed to not wear masks while on the ice or in active participation. The city of Aspen's response to that was that we as a city will not be granting an exemption, nor do we feel that we really can outside of the public health order. And so I just wanted to know at the ARC advisory board meeting, they had representatives from public health there. They spoke to them. I just want to know if that's going to be discussed at all. I just want to get proper communication out to our ICE users about their request and about anything from this board or public health.
Thanks. Tori. Jordana, are we doing that at 3 on our calendar? Is that for the public comment survey? Is that where you wanted to discuss this?
Exactly.
Okay, so we're going to hit that about 3, Tori. Or actually, we're about 15 minutes ahead of schedule, so maybe 2:45 if we keep moving here. Thank you. Thanks for bringing that up. It has been on my mind as well, and at this point, I think everybody has seen all the public comment as well. Okay, ready to move on here to is it Joanna? Or no, sorry, Dr. Levin. You're up next.
Yeah, hi everyone. I hadn't seen the earlier part. I'm in the ER right now, so just jumping in, but I know that a lot of data was just presented. And if you want to do the next slide, I think that's the matrix. Yeah. So this is the updated matrix, and it's just unbelievable how things have changed since our last meeting. I was just thinking back, and we were in the green on December 8th, and the changes that have occurred in this pandemic just over the past month since our last meeting have been incredible. And I think it just really lends to, the unpredictability, how fast Omicron came on, and what we have to, prepare ourselves for something, again, similar happening to this in the future. But so we're, the matrix, so the overall status now for AVH is in the red, which is concerning. And then the 3 different categories: healthcare workers, the outpatient daily visits, and inpatient hospitalizations, red, and yellow. These changes happened very quickly. Healthcare workers went into the red. I think it was on December 22nd. We started surging around the 19th or 20th. And And then outpatient visits went to yellow and then to red fairly soon after that. I think it was right after the new year. And then inpatient hospitalization staying in cautious at this point, being that the numbers are still low. So I think what happened to a lot of organizations, including the hospital, is the staff and the percentage of healthcare workers. The number just shot up in terms of healthcare workers out, and we all know that the isolation guidelines changed, which helped get people back, especially essential workers, back to work sooner rather than later, from 10 to 5 days. That helped out, but I think about 30% of the overall workforce at AVH has been impacted since December 16th. And so that's what really has led to this rise in red, and the impact that that's had kind of throughout the hospital, never really having seen that this would be what would stress the hospital or the healthcare workers out. So although the numbers are starting to improve, we're staying in the red at this point. Really looking forward through the winter at anticipating likely this roller coaster ride, most likely in terms of having, the X Games coming and Gay Ski Week, and probably little rises and falls, and hopefully nothing as major as what we've just been through. But at this point, the status is staying at this, and we're constantly reevaluating. Every week we discuss and have in-depth conversations of the numbers and the data. And I think that this is really just a warning to the community that we're in it still, and it's live and happening in the hospital. Things are under control. And again, there are more healthcare workers coming back now, and the numbers seem to be improving. And we'll just keep tabs on it and keep watching out. So I think that's basically it for the matrix. And if anyone has questions on that, I also just wanted to mention a couple other things that are happening. There's been so much, just such moving parts here, but there's a couple of medications. One of them is Paxlovid that you may have seen most likely in the news. And this is being kind of divvied up by the state, and we do have a number of doses in the Valley. And I just wanted to let the public know and let you know that it is reserved for people who have high risk conditions. And so the medicine is to prevent hospitalization and death. So kind of prevent the severity of disease. So anyone who has a COVID positive test, who also has underlying medical problems, please talk to your doctor as soon as possible to see if you might qualify for this medicine. It needs to be given within 5 days of symptom onset. And so there's a timing component to this. And so it's really important to talk to your doctor right away and see if you qualify for this. And so people with high risk conditions are over the age of 65, diabetes, type 1 and type 2 diabetics, people with chronic lung conditions, people with heart conditions, and a number of others, immunosuppressed, cancer. And so this is what these medicines, we have a limited supply at this point. We know that more will be coming, but the medications now are really reserved for high-risk people. And again, it has a EUA, it's emergency use authorization. And so it's still under investigation, but there's evidence that it may help prevent the progression. So it's not a treatment, it's just helping to prevent hospitalization and death for people who are at risk for that with COVID. So I just wanted to clarify that. There's also the monoclonal antibody treatment that you may, similar indications, high risk conditions, and everyone else who has COVID positive tests, just take care of yourself and supportive care at home. But again, if you have any questions about whether you're a high risk person, talk to your doctor and find out if you qualify or not. And we can try to get that medication to you. And that's basically it, unless there's any further questions.
I don't see any hands up. If anybody I don't see on the screen, holler if you're looking for a question. Thanks, Dr. Levin. Appreciate you checking in with us. It's good to know that it seems like things are getting better in terms of employees out. So maybe we are approaching the descent side of the curve.
We hope so. Fingers crossed. I mean, the numbers are still high, but hopefully the trajectory is going down. We still qualify for being in the red. Yeah, fingers crossed that this starts getting resolved. And I think, again, it just kind of lends itself to the unpredictability of the pandemic and the need to always have a response plan and just be prepared at any point and have flexibility to have plans in place and communicate with the public about what's happening in the data and the numbers, so that can wear masks and get vaccinated. And those really are, prevention is the #1 tool.
Great. Thank you. Thank you very much.
Thank you.
We're going to keep moving here, and we're on to the community liaison update with Joanna Coffey, who's our consumer and employee health protection supervisor. Joanna, are you there?
I'm here. Good afternoon, everyone. Just wanted to remind the public that effective with our public health order from December 1st, 2021 till May 1st, 2022, any event with 50 or more people, regardless of if it's indoors or outdoors, requires an event safety plan to be filed with Pickens County. So this is just a great way for the event planner to let us know what's going on and walk through different mitigation strategies. But I just wanted to talk about 2 upcoming events that we had. We've been working really closely with ESPN for the X Games and with Gay Ski Week. Unfortunately, they were not able to come to this meeting, so I'm going to just give a quick update on their guidelines on behalf of them. So the X Games is going to be coming on Friday, January 1st till Sunday, January 3rd at Buttermilk. Last year, they did not allow any spectators, but this year they will be allowing spectators to come in. They do have a spectator limit of 7,000 people per day, but there's no need for advanced ticketing and it's all free. However, they are going to require that anybody that wants to come and watch in person who is 12 or over provides a proof of full vaccination. So if it's a 1-dose series with Johnson & Johnson, 2 weeks after that, otherwise 2 weeks after a 2-dose series of Moderna or Pfizer, and they need to show a identification photo that matches their documentation for their vaccines, and then they'll receive a wristband that they can wear for the next 3 days, and that will allow them access to watch the events. For any kids that are 11 and under, they can be admitted without proof of a vaccine, but they must be accompanied by a fully vaccinated adult, and the children will have to wear a mask at all times. Regardless of when you're showing your proof of vaccination, it's still a requirement that if you're indoors at the bumps or any of their facilities for the X Games, that you wear a mask if you're not actively eating or drinking. And since they are going to have this vaccination card checkpoint, they're going to have it, of course, at Buttermilk Thursday, Friday, Saturday, and Sunday. But if you want to get ahead of the game, they're going to have a verification Thursday, January 20th from 2 to 5 p.m. at the RAFTA Ruby Park Transit Center. So you can go there and show your identification and vaccine card and get your wristband ahead of time. They're also going to have that at the Brush Creek Park and Ride Friday, January 21st from 5 to 8, and Saturday, January 22nd from 11 to 8 p.m. And for the most up-to-date information on the schedule and other COVID guidelines, you want to visit xgames.com/Aspen. Next slide, please. We're also excited to welcome back Aspen Gay Ski Week. They're going to be starting this Sunday, January 16th for a week through Sunday, January 23rd. They're going to be kind of all over the 4 different mountains, but their home base is going to be at the Limelight Hotel, which is an approved, fully vaccinated facility with the Pickens County Public Health. As a result, they are going to have about 450 guests a part of this program. All the guests have to show a proof of vaccination, and they'll receive a wristband for the whole stay that they're there. They're going to have security and staff checking at the event for the wristbands, and 100% of the staff and volunteers are going to be fully vaccinated and have to show proof of that. They are still requiring masks at all indoor facilities unless it's an approved, fully vaccinated facility with Pickens County Public Health. And additionally, they're going to have on-site testing available for affordable prices for the public and anybody that is part of the event. And for their information, you want to go to gayskiweek.com. That's it. If you have any questions, please let me know.
Questions for Joanna? I just had one question regarding, it seems like there will be an awful lot of people at the X Games, and it's been a long time since I've been, but I remember just crowds packed in like sardines, like the rock concerts, or at the venues on the side of the half pipe. And so it's gratifying to hear that they're masked up. The adults won't be, but they'll be vaccinated. I guess that's. I'm just wondering if things needed to ramp up. If something, say we have. I guess we won't know if there was an outbreak until they're all gone. So keep our fingers crossed, really. But I just wanted to check in with everybody to see how comfortable you are all with that, because quite honestly, I've just had a need to avoid crowds this last year or two. I don't know, Jordana, maybe or you or Dr. Kurt, I see has his hand up. Let him go first.
Is the Winter School doing anything this year, Joanna?
Well, off the topic, but it's good to know. That's a good question. Regarding my question, I don't see anybody jumping in. Jordana, do you have any?
I would just say that, I think we're continuing to promote the status, even across Colorado, across the nation. Omicron is at a height of being pervasive, and, one in 15 Coloradans, or is it 5 to 15% of Coloradans probably are infectious at this point in time. So it's a great idea, even if it's not a requirement of the X Games for adults to have to wear masks, for people to judge their, to bring a mask with them and use that as an additional layer of protection. So, we've got some great measures in place, and then we continue to put out the message that people can continue to be more protective, or if if individuals have conditions that put them at higher risk, maybe deciding not to hop into the crowd, right? Making those decisions based on your own risk level as well.
Great, thank you. And Joanna, did you have any information just on the signage, the messaging that X Games is doing to the crowds as they're coming in? People will be reminded, I assume, with signage, and do we know about that?
Yes, they're going to have large signage reminding everybody for indoors to wear their mask and to give everybody space. And then just to Dr. Kurt's comment, the Winter School has submitted an event safety plan. They're going to be doing their snow sculptures that they usually do, and they're going to have a small bonfire in Wagner Park if they continue to do the fireworks. But we'll let you know if they update that at all.
Right, thank you. Appreciate it. Good luck to all of us. Keep your fingers crossed for the next week or so through this, and hopefully we'll get through it. And as we have a track record with X Games and other events here, that doesn't seem to be huge outbreaks after these. So I think that's accurate. But I'm optimistic. Thanks, Joanna. Let's keep moving, and we're on to Carly and our vaccination and testing update.
Thank you, everyone. If anyone has a hard time hearing me, please let me know. I'm in a building about to go to a vaccination clinic, so masks on. But I know sometimes it can muffle. So the few different updates since the last time I presented to everyone here. The big one is about boosters, or those additional doses. So both mRNA vaccines, so Pfizer and Moderna recipients who received those two mRNA vaccines for their initial dosage are now eligible for a booster 5 months after that second dose. So previously it had been 6 months, it is now 5 months. So this kind of opens it up to a whole other extra month of individuals who are eligible. We are also really excited to announce that Pfizer has been approved by the FDA and the CDC for booster administration in all individuals 12 plus years of age, as long as they are 5 months out. The other really big move is that boosters of Pfizer are also approved in that pediatric demographic, so those 5 to 11-year-olds who are moderately to severely immunocompromised. So this group is aware, those are individuals who really should be consulting with their care teams and their primary care physicians to determine if receiving that additional dose at this time is appropriate for that patient and that child. So we at Pickens County Public Health and Community Health Services are not going to be administering those doses at this time. They really should be in consultation with those physicians. So just so everyone here is aware, and that is really because the pediatric dose just got approved a few months ago. And so we really want to make sure that those boosters are being administered in line with the FDA and the CDC, which is very exciting. And then the other really big one is that the CDC and the FDA both came together earlier this month to decide or to vote and determine that the mRNA vaccines are highly preferentially preferred to the Johnson & Johnson, which is a bit of a mouthful. They did not disallow the use of Johnson & Johnson. They recognize the value of Johnson & Johnson within certain demographics or for those individuals who may suffer an allergic reaction to those mRNA vaccines. But we really are kind of aligning ourselves with the CDC and the FDA and really pushing individuals to receive either a first or second dose that is an mRNA vaccine or a booster dose, those third doses, which is also mRNA. So really pushing those mRNA vaccines. We know that they are safe. We know that they are so much more effective technology-wise and safety-wise to those Johnson & Johnson. So we're really encouraging individuals to seek those out. A little bit of a testing update is that our community testing sites who run our Microgen DX tests are setting up a local lab in Mid-Valley, which is going to allow for roughly 1,000 24-hour turnaround PCR tests each week. So a pretty substantial number. It's really exciting to see. We already have wonderful partnerships with those groups. Right now, our testing turnaround time is 99%, getting turned around within 2 days, but we know that Omicron is moving quickly. And so we really are appreciative of all the efforts to bring that 24 testing turnaround time to Pickens County and the Valley as a whole. So really looking forward to that at the end of January. Keep an eye on the Pickens County website and those community testing sites. They'll have more information about that going forward. Excuse me. Ongoing into the rest of the winter and into the springtime, we will continue to have vaccination and testing opportunities throughout Pickens County. Please check the Pickens County Public Health website for any upcoming vaccination clinics or any changes to those testing requirements and scheduling. Just to recap and briefly retouch on what Josh had presented earlier about our PCRs versus antigen tests and sort of when we prefer to use each of those tests and where they sort of belong in our go-to testing strategy. PCRs are still the gold standard for that diagnostic testing. And so if you are symptomatic and you hypothetically take an at-home antigen test and it comes back negative, we really do encourage you to go seek out that confirmatory PCR at one of those community testing sites, especially if you're symptomatic, especially if you think that there's a likelihood that you've been exposed, just to really know that those PCRs are still the gold standard for that diagnostic testing. Antigen tests across the board, whether it's at a provider or with those at-home testing options, are really, really useful for that CDC's recommended option to test on day 6 after your isolation has started. So again, just to reiterate, on day 5, if you are feeling better, you have no fever, on day 6, if you take that antigen test and that comes back negative, you can be fairly confident that you are no longer shedding viruses and are no longer infectious. So that we just want to make a quick designation that PCR is still very effective at diagnostics. Antigens are much better to determine after you coming off that infection, after you're feeling better, after you're fever-free, to determine how or potentially infectious you are. So just wrapping it up there, short and sweet. Any questions?
Thank you, Carly. I did have a question just regarding the antigen, just the effectiveness of the antigen. I've heard something like 55% effective with accuracy. It sounds as if they've actually isolated a more accurate time to be using it. Is that correct? I want to understand that.
Yeah, and if we, as I know Josh had the wonderful graphic that was on his slide that kind of showed throughout the days. So once an individual starts getting tested and receives that positive, and we know that that viral load is high. So yeah, most people are testing on, that day 1 or 2, and that's when that antigen test isn't as effective, even in symptomatic individuals, at picking up that infection, which is why we really are trying to encourage that PCR test for that diagnostic portion.
Great, thank you. Thanks for that reminder of the graph as well. Together I'm getting to understand this. Okay, if that's it, we're going to move on to the communications update. And Tracy, I see it's on. Welcome, Tracy.
Good afternoon. I'm actually going to have Rachel Brenneman kick us off today with our update. So I'll let Rachel take it away.
Welcome, Rachel.
Good afternoon, everybody. We've got a number of updates for you. We'll keep it short and sweet too. Lots of programs continuing, and then a few new comm strategies as well. So you guys will hopefully remember from last month, we talked about our For the Love of Winter campaign. That has 3 main messages around it. For the love of winter, get vaccinated, wear a mask, and get tested. Since the middle of December, that is showcasing over radio, print, and digital in English and Spanish. Lots of stats here on the right. One thing I want to point out is our La Tricolor partnership. Lots of impressions there and lots of clicks with public service announcements like what we're talking about here. A lot of times there isn't an action. We're not asking people to sign up for an event. So that click-through really tells us that there is a desire for this information, especially in the Spanish-speaking population. Next slide, please.
So I'm going to talk about just paid social media campaigns. We know that social media tends, to be a channel that people pay attention to and that we get engagement on. So we did a really hard hit on social for when COVID cases started to quadruple, not a message we want to deliver, but an important message we felt for the community. And again, you'll see that it was viewed and clicked on quite a bit. Again, for the love of winter and support of that campaign. And then we just keep trying to drive people to our push notification, which is our newsletter, and sign up. And along with the newsletter, you also get this data summary push notification that comes out on Thursdays. Go ahead, next slide, please.
So to support all the amazing work that Carly and her team are doing, we're continuing to do print ads as well as digital and social for the vaccination clinics, whether it's CHS or the state Vax buses. We're continuing to push that. Next slide. And our newsletter continues too, as well as our weekly data summary. Our newsletter, we have cut back a little bit. We're doing that twice a month now, but the weekly data summary goes out every Thursday. Today was our 15th. So we've been doing that for 15 consecutive weeks, which is cool. As you'll see here, our open rates are significantly above the industry average. And they've kind of crept up a bit since we reported last. So those are looking really good. The click-through rates are doing well as well. Next slide. So our weekly data summary, it's really starting to gain some traction in town, which is exciting. It is in print on Fridays in the Aspen Daily News, as well as the Aspen Times. It goes out Thursday via our email newsletter list, and then it also lives on our website indefinitely. A new thing that we're adding to the mix as of last week is a continued partnership with Aspen Daily News. You guys might be familiar with it. I know Tori is, because he's one of the awesome hosts. They do a local morning show, 6 days a week, filmed live from the top of Aspen Mountain. And every Friday, I send the data summary to their team, and every Friday, their host, Diana Lane, goes through the data summary piece by piece and really communicates that to the public. So exciting new avenue for that data. The audience for the local morning show is both visitors and locals. The folks that are watching it on TV are mainly visitors, but they also broadcast it through their website, and then there are links on the Aspen Daily News website that is seen from people across the country and the world. Their traffic is pretty incredible, the diversity of the geography of the folks that go to that website. So anyways, excited to have a new venue there. We'll talk a little bit more about the ADN partnership in a minute. Next slide.
Just wanted to be aware that Pickens County, actually not just the COVID team, but through the county channels, has made some updates to our websites in support of Gay Ski Week being in town this week. And so you'll just see we've kind of done a few updates and reminding people, putting the rainbow banner on things, that's something that we support. And so that's going to be on not just the COVID channels, but also the county channels. And thank you for that great image of Jordana on this particular picture, having one of her children vaccinated. Next slide, please.
You guys have heard me say this before, that our website traffic generally mirrors the national case count. As the case counts increase, our website traffic increases. As it decreases, so does our web traffic. So you'll see here on this top left graph in the blue, this fall and into early winter, we were kind of cruising along, and then Omicron hit, boom, and you'll see a big spike in the traffic there. On the graph below, the orange line is November traffic, and then the blue is December. So again, showing that pretty major increase there. I was relieved to see that we had a dramatic decrease on Christmas. So thank goodness people are opening presents and hanging out with their family instead of on the COVID website. But looking on the right here, the way that translates into numbers is we saw about an 80% increase from November to December. So a pretty massive jump there. And then as far as our Spanish pages go, you guys may not know, but our entire website is bilingual, Spanish, English. And we saw almost a 200% increase from November to December on the Spanish pages in general. So big jump there. We're excited to be serving that audience. Next slide, please.
We also, with the rise in Omicron, did a lot of work with Aspen Valley Hospital in partnership with them. So they had a full page ad they needed to get done before the end of the year. And so they partnered with us to put out this message. And the nice thing about it is the vaccine team was actually seeing people bring it in with them when they came, or talking about how this is where they found the information around getting vaccinated. So, we're finding that, people, again, I think having that consistency of a message that we're running that's a little more evergreen has been definitely getting us some of the attention that we need to keep driving people back to the healthy best practices that we need to keep practicing. Next slide. And then also just touching back on our Spanish outreach and equity efforts. Again, if you haven't met Rosa Sacedo on our team, she runs our call center and is just a tremendous resource for us to the community, and also giving us just the pulse of what's going on or where we need to be doing more work. Our team is going to go into a planning in the first week of February, kind of after public health has done some of their strategic planning, hopefully, to kind of talk about what the next 3 to 6 months are with COVID. And then maybe even, after that, I know for many of you that are here on this call, Kim, I'm thinking of and Jordana, I think it was March 8th of 2 years ago that we're coming up on, where we all kind of started to kick off this response. And so just figuring out how we continue to bring those messages forward to the community in an effort to support them through COVID. I think that's the last of my slides. Rachel, you want one more?
I think so.
A couple more.
Well, yeah, Aspen Daily News. So in addition to them sharing our data summary, we also each week have an opportunity to do a live interview with them. And we've had Carly talking about vaccine and testing. We had Georgiana talking about just general updates. We have Joanna Coffey, who you heard from earlier, going teed up for Monday. She'll be talking about X Games as well as Gay Ski Week and what that means. We brainstormed a little bit today, actually, and are talking about bringing in the mental health folks from public health as well. As we know, that's a big issue right now too. Next slide. So Aspen Daily News has been an incredible partner, and they've kind of gone above and beyond. And they've actually put together a 30-second, commercial video around For the Love of Winter. And this is shown on the local show as well as the ISIS Theater. So the ISIS Theater now shows ads ads before the movies, which I definitely have mixed feelings about a little bit, but it's a captive audience. Folks are sitting there eating their popcorn, watching the screen. So this spot will show, it started Christmas week and will show towards the end or to the end of March on all 5 screens before every movie at the ISIS Theater. So a great way to get some views. So we'll play it here and see if we have any luck with the sound. Thank you, Alicia, for your amazing driving there. Way to go. One last plug, and then that's it from comms, is that we did push live a blog today talking about masks and the effectiveness of different types of masks as well as the fit. So if you go to our homepage, check that out. Jordana, I appreciate your distinction between the N and the KN95. So we will actually add a little bit more information to that, but it's a good resource. We'll be pushing that through all of our channels next week. That's it. Any questions?
I'm looking for questions. If I don't have any, thank you, Rachel. Thank you, Tracy. It's great to see this. Joanna, did you ever hand up? Was there something you wanted to add?
Yes, sorry. I just wanted to clarify for the winter school, they will not be having a bonfire. They're just going to have snow sculptures for everyone to look at and fireworks. Sorry about that.
And the sculptures will all be masked, I understand. Is that right?
Yes, they'll be ice masks.
Okay, Dr. Kurt, was that a hand up or are you good? You're good. Okay. We're on to Kurt and wastewater. Thank you, Rachel and Tracy.
Thanks, Greg. Good afternoon. Wanted to give a quick update on wastewater monitoring with the State Health Department. We've previously been talking about this the last few board meetings. The City of Aspen Wastewater District has started sending samples to the State Health Department. It started December 20th. The state has run a few samples, however, they haven't gotten them uploaded into the system yet. This slide shows a copy of the portal that I get to see when I log into the system, and you can see there isn't any data. The left-hand graph is the wastewater surveillance information, and then it compares with the right-hand graph, which will be the the sewer shed, sorry, not watershed, but sewer shed case rates. So the incidence rate for the area the sewer serves. If you can go to the next slide. So I copied in what those two graphs will look like, just to give you an example. This was just copied from a different water or sewer shed in the state. And you can see that on the left, that's the volume with positive for the COVID not vaccine.
Variant?
The variant information's on the bottom. Thank you, Jordana. But the virus itself, the right is the case count in the watershed. And the important thing is that they're actually not just comparing, say, Denver, but the sewer shed that is being served to make sure that this is accurate. But you can see how they parallel each other. The information from the sewer usually is a couple of days ahead of the actual case counts on the right. So the other piece that's really great with this, on the very bottom of the left-hand graph, you can see the colored dots. And those represent the different variants of COVID that they're detecting in the wastewater itself. So one of the useful tools will be for us as we start to see other variants potentially in the future. This might be a way to isolate fairly quickly when we see that. So we're hopeful to get that information on. I talked with Bruce today at Aspen Consolidated Sanitation to talk with him about the data that the state still needs. They're looking for this information around the GIS, the actual area that the sewer serves, so that they can get that information in the system correctly. Bruce and I talked about If they do not have that information, I'll coordinate with our GIS department because I believe they have that information as well. The other update, we had been talking with Snowmass Village about starting this program. They had expressed some interest, had some concerns around the data and how the data would be looked at based on population. I think there were just some concerns knowing how our population ebbs and flows over a year with visitors and even staff, how that might appear. So I've checked in with Kit, who's the manager there, to see if they have had those issues resolved with the state and if they're still interested in the program. With that, are there any questions?
Oh, I don't see anybody. Thanks, Kurt. I appreciate interesting. Glad we have this tool in the toolkit. I'm not seeing anything. Should we keep moving? Anything else you want to add, Jordana? We'll just keep going. Okay. Thank you, Kurt. Public comment survey. Jordana, I'll let you tee this up. I think everyone was emailed all the public comments. We have a new form for taking them, which seems to be working pretty well, both the county and the public health department. So I'd love to hear your thoughts on that, and let's start it. Go ahead.
Yes, Greg, if we go to the next slide, it does go through the current public comment process. So ahead of Board of Health meetings, we have this public comment form that will always be available. So all questions and feedback that get received up to 3 days before the scheduled meetings get compiled and sent out to Board of Health members for your review before the meeting. So for this is our first time using this process. All the public health comments that were received and reviewed by you as public Board of Health members covered these several topics. There were requests to move in-person school to remote learning, comments around that COVID protocols had a negative impact on mental health and well-being for children. There was a call for more mask enforcement. There was a request to require N95 masks. And then also the request that Tori mentioned around allowing youth hockey to have a mask exemption for anyone 18 years and younger when they are on the ice. So that's kind of a summary of what came in. If we go to the next slide, I can share just the staff recommendation and happy to talk about any of these requests or the recommendation in more detail as well. So specifically, the recommendation is to maintain the current public health order and mask requirements with no additional exceptions, including, Tori, the exception for youth hockey players on the ice. So the reasons behind this recommendation are that we are currently seeing a surge in the incidence rate in Pickens County and Colorado. Several key employers, the school, hospital, have expressed concerns to us about the number of staff out with COVID. We heard from Dr. Levin earlier about this, the hospital, both COVID and COVID-like illness that is currently impacting, may impact operations or is a concern for impacting operations. We know the state has enacted some crisis standards of care protocols in certain settings, that hospitalizations are still expected to continue to be rising around the state, which do impact our ability to transfer. We have recently followed the CDC guidance to shorten that isolation and quarantine time period. So we're really waiting to see if that has any other additional impacts locally. And then as Josh presented in detail, masking does help not only slow the spread or reduce some transmission, but also reduces severity of disease. So I'll just turn it, Greg, probably back to you to see if there's any additional questions or discussion.
Right, thank you. I guess I would kick this off just by saying that I did go through and look at the correspondence we've had from all the parents and advocates regarding this. I spoken, or at least via email, with the county commissioner in San Miguel County about their public health order. And then also I saw and flagged, of course, the public health order from Eagle. The hard thing, I think, for us and for our board and with this decision is that Eagle has relaxed their mandates for sports teams. And it's just, I couldn't understand why. I think I asked our staff, like, why are they doing this right now? Not sure it makes sense to me as Omicron is spiking. And you probably can see that in the correspondence. I don't know if you'll see that report, but we could easily get the order from Eagle County for what it's worth. But since that affects our watershed and our valley, once again, we have counties that, side by side that have different sets of orders, and that's, that's troubling as always. In Telluride, I asked them if they were, what was up, did they have any ice rink rules regarding hockey and ice? And they said, well, we don't, but the only outbreak we ever experienced is when we came to Aspen to a hockey tournament, and we all came back with COVID. We did have our largest outbreak that our community has experienced, I understand, has happened at a hockey tournament here. So thus the concern and the caution that we're seeing. I just want to make sure that anybody listening to this understands that we've reviewed all this information, and I'm hoping our board has had a chance to go through it. And what I'm hoping to have is a conversation here. We did have requests for public comment, but I have to say it. Really, this Board of Health is entrusted with, setting the policy for the safety for the community with our public health department. And this isn't the sort of thing that you have a public process and debate over. Unfortunately, that's not what public process is for. So all public comments are welcome in the form of the letters or online, but we're not going to have public comment live in person, because that could go on for many, many hours. I'm not sure it would really change the outcome, because at the end of the day, it's up to this board and our public health department to make the call, whatever the call is going to be. So with that, I would like to have a conversation about this, only because out of respect for the work done by the people who submitted their request, I thought it was quite thorough, quite honestly. And if not thorough, at least it was comprehensive, and they put a lot of effort and time into it. So if you don't mind, Jordan, I don't know if there's anything you want to add to that, but I just wanted to open this up for a conversation with our board now, and I'll recognize anybody who would like to say something. Did I cover it? Dr. Kurt, okay.
I'll mention that the Wheeler announced this morning that tonight's performance and tomorrow's are being canceled. Unfortunately, it's due to staff illness, not other factors.
Right, got it. This does seem like a really awkward time to be relaxing a mandate, and that's why I questioned what Eagle County did. They have their reasons and their data and their the policy. But it's a tough one. I understand, but I have to say this does seem like the wrong time to be relaxing this. And I'm hoping we see the Omicron spike decline rapidly, and we go into the next trough. And I've asked Jordana to give us a prediction of how long that will be exactly, so we can all book our vacations and be safe, but she's not willing to. But I think as for now, the impression I'm getting at this simply isn't the time to relax this. But when we do have that opportunity, Jordana, what is your policy regarding hockey or any other sport?
I'm happy to share that. I know Tori also has his hand up. You want me to?
Either Tori, are you frozen? He may be frozen. No, he's just sitting still. It's hard to tell. You have to blink, people. Otherwise, I think you're frozen. Did you want to say something, Tori, or are you?
Yeah, I appreciate it. Thanks a lot, Greg. And I guess just for me as a representative, I'm just bringing forward things from my constituency and the work that we've done at the city council and with our staff working with these hockey users. Greg, I really appreciate the fact that you did some investigation on your own and reached out to some other counties. I had the opportunity to do the same thing. I've spoken to Telluride, Vail, Steamboat, and some others. So it does seem like there are some public health orders that do have exceptions written into them for ICE users. So my council as well is split on this. We would agree with the chair's position that right now we're not looking for any movement on this in the height of another surge and where we are with these cases. So we don't feel like we know enough about it to make a request for anything, but we just wanted to support our community members that are interested in getting the information about this. You know, it's very difficult as we see it being treated and handled differently in our close neighboring counties as well. And we're sending some of our kids are actually traveling to these counties and they're under different guidelines there. So, you know, I'm not going to go into the pluses and minuses of what the arguments have been for and against. I just wanted to say that I really appreciate both Jordana and public health staff and the team, as well as board members giving this consideration. And I think that we all understand that right now is not the time to make any relaxation in the regulations that we have with the uncertainty that we have. But our hope is that as we move forward, you know, that we'll be able to revisit this, that as we watch our numbers, that we can have another discussion about this. But then really overall is that we start formulating, you know, the real long-term plan that we have for dealing with this and living with this and moving forward with it. No telling what the virus is going to do, what turns it's going to take. But at some point, we as a community and as a region need to figure out how we're going to be moving forward with the assumption that this is not going to go to zero and that we need to learn to live with it. So I just want to say thank you guys so much for the consideration, and hopefully we'll be able to talk about this again when we're not in the same conditions as we are now.
Thank you, Tori. I really do appreciate that. I'd like to point out also that I did pose this question to my board about Board of County Commissioners, and we have a majority who think that we should stay the course until, you know, the Public Health Department sees some progress in reduction of incidence rates or whatever other indicator you're going to use. So thank you. I don't know if Jordana, you want to add anything else to this? I think we've covered it.
Can I add, Greg?
Yeah, sure. Thanks, Patty.
Yeah, I just want to say, yeah, we did discuss it, but part of our discussion also included the public comment issue that came up from, I think, Scott Ryder about public comment in person, blah, blah. And I want to make it clear, as I think we did at our work session, that we take public comment seriously. And if it comes in electronically, we all get copies of it. We all read it. We all take it to heart. And I think the public needs to know that. So, and I want to make sure that Scott Ryder knows that that we read his comments carefully, took them into consideration, and that we will be following up in the future, as you said, Greg, when the numbers change. It's kind of a living virus and a living order, and we have to go with it day by day. But I want to make sure the public knows we do pay attention to their input, and we appreciate it.
Thanks, Patty. That's true. It's a good point. The public comment is certainly important and appropriate, and this will be an ongoing conversation. I'm hoping that you know, if nothing else, we get a technical fix for those who breathe hard, like hockey players or other sports athletes. Perhaps there'll be a mask with you know, positive air pressure or something, so they can still be masked and function at full capacity. I know how hard it is to wear a mask and do anything. So I sympathize, and I feel better informed on the topic thanks to them, and also thanks to the input we've had from Jordana and crew. Okay, I'm gonna keep up Dr. Giesel.
Thanks. Can you hear me? I just wanted to have, I think besides the hockey issue, there was also the letter that was sent from I don't remember what they were called, but they were kind of the mothers that were concerned about mental health. And I did just want to give them a little bit of airtime right now too, because that was a very extensive letter and a lot of research. And I think that, you know, this is definitely kind of this younger childhood area. I've definitely been hearing from a lot of people that have a lot of frustrations on this particular age group, and my heart just goes out to you. I can't imagine what it's like to have very small children right now. I think a lot of this is just being, what we have adopted for our county is coming from the CDC, and I don't feel like we have a lot of ability to veer from those guidelines. Again, I hope that this Omicron variant goes away as quickly as it came and things can be a different place in the near future, but I just wanted to let you know that we hear you. I think that we're doing what we can with masking in order to help keep our children together and socialize, because I personally feel like that's the most important thing for mental health for the young children, is just to be around other people and have some normal experiences. And mask to a certain extent is allowing us to do that. Vaccination, if they're old enough, I realize that's not the case for these children under 5, and that we do hear you.
Krista, thank you very much. I want to point out that Patty and my associate Kelly Nicholas Curry has 2 very young children, I think a 4 and an 18-month-old, and she's been extremely concerned and taking every possible precaution to keep her kids safe and to keep her family safe. And she is probably our most strident advocate for masking and for vaccination. And she's just so frustrated because she wonders why anybody in their right mind wouldn't be doing everything they can, because she has her own, her children remind her every day. Anyway, I wanted to point that out, that really there's an argument for masking, and I know we see the full range here. If we looked at the public comment, you saw people advocating for masks and against masks, for relaxation and for making the rules more extreme. We had one local doctor weigh in recently with texts and emails to me, and I noticed he made a comment that, we aren't being stringent enough. We should be demanding 95s everywhere. So we're walking the fine line, and we're walking the knife edge on Capitol, as I like to say. And I want to congratulate and thank you all for muddling through this with us. And I think we'll keep moving now, but so that the public knows that they are heard and appreciated, and we empathize, and we're going to keep trying to keep the community safe. Okay, we're going to move along. My screen just went blank, so I've got to find where we are here. We're at round robin now, so if something else needs to come up, this is an opportunity. I'm looking for hands, or if anybody wants to kick it off. I'm not seeing it. Boy, everybody's so quiet today. Okay, Tori, thank you.
Sure,
I can
given the
always count on
opportunity,
you.
I'll take it. I appreciate it, Greg. Yeah, I just want to take one more opportunity to bring up mental health. Some of what Dr. Giesel was just speaking about. The city has been engaged in some outreach and awareness, but there's also members of our community, such as the Here House, that are scheduling some different mental health programming as well. What we've been looking at from the city side is, we don't really have the resources, or maybe the departmental resources and staffing to really have a public health arm. So we've been having some conversations and looking at things that we can do. And I just want to bring back to this board and the public health team that I plan to be asking for some more county participation, or some leadership from public health team in this area, because we just don't, this isn't our lane. It's just not our strength. We don't have the resources really for kind of some small steps that I think would be very instrumental. So just wanted to bring it up once again. I'll probably be reaching out to Jordana and maybe look for a small section on the agenda next meeting or something. But I just want to put that in front of us again, that mental health awareness and some of the programs that are going on could still use some more support. And I'll be coming back to the Board of Health for maybe some ideas from everybody.
Great, thank you, Tori, and please do. I think Pitkin County will be eager to engage and stay engaged on this. It is important, and it's good to see everybody focusing on it. And what I think we'll discover is we do have a wealth of resources here, but we also have a very large demand, and certainly there are gaps. So I welcome that conversation, and let's get it on for the next meeting agenda then. I did want to point out, if anybody's been following the recent news regarding Mind Springs Health, and Mind Springs Health is currently restructuring, so to speak, in that they have a new director. The director retired early after some scrutiny from was an article written by a Denver journalist who did some investigative reporting and discovered discrepancies across the state in mental health programming. And Mind Springs was only one of the several that there were a lot of questions. And Mind Springs is going to be coming to us. They've reached out to us, the interim CEO. They're being very proactive. They're going to be engaging with us at the county level because we support them. I personally have done a lot of work on their behalf in recent years, and so I'm especially interested in seeing that they engage with us and we get back on our horse and clear up the issues. Good luck to us with that. It's a huge organization. I think what we're going to find out at the end of the day is that they're under budgeted and overworked, and they were doing what they could to keep it together. So I have a feeling that it's going to come back and say we need a lot more money for mental health in this state, and I just anticipate that's what it's going to look like. But we also have our state legislators involved in this as well. So we'll be hearing more from them. I don't know if we'll get them on the agenda for public health, but if anybody has an interest, I suppose we could. After the meetings with our county management and BOCC if necessary. Just wanted to bring that up. Anything else on that topic from anybody or any other? Jordana?
Just want to recognize, Greg, that yes, systemically, we're very interested in what comes out of the examination, and then also at the same time wanting to recognize our local practitioners, clinicians, peers, managers at Mind Springs who we work with closely and are doing a fantastic job on that individual level and individual service provision level. So just a thank you to all the work that they do to partner with us and provide that mental health services locally.
Great. I do appreciate you bringing that up. And we certainly do have respect and appreciation for the workers and the people in the trenches. And so I think that what will result from this is a stronger Mind Springs Health at the end of the day. And so I think it's painful when it happens, but it's going to have a silver lining at the end. Anything else here? I'm still in round robin. I'm looking for, I think we've worn everyone out. Just checking my magic screen here. Hi, Ann. Hi, Bill. Hi, Claudia. You're all still here. Okay, you're not frozen. Those aren't just avatars. Okay. Okay, then. Next meeting date. This is the big question for all of you. Dare we take advantage of the coming trough in the COVID curve that I'm predicting, and go back to what we would call a regular meeting schedule for Board of Health, which would be every other month. It'd be great to get to quarterly as the CDPHE mandates, but dare we take a chance and plan our next meeting for March 10th? Thoughts? I see smiles. Okay, well, I'm still looking. Nobody's weighing in here. So I think that Jordana, I would recommend that and ask that we take a chance. The worst thing that could happen is that we call a special meeting. If there are any public health orders that you need to issue and you need our support, if you need us to tell you now that, if there's anything else we need to authorize you to do or, make the call as you see it, really it's going to be on your shoulders, and you won't have us on a monthly meeting, but we'll be back in 2 months then, barring hearing the need for a special meeting. Were you going to add something to that?
No, just that we've already got written into our public health order the additional triggers if the hospital does have to, if that capacity is challenged, that is kind of a standing, it's already in the public health order of the, if they have to cancel all elective surgeries, that we would go to 50% capacity across the board or 100% vaccination verification.
Okay, well, conversely, then if things start looking good, how quickly can we relax masking for things like hockey or sports, or how does the relaxation come? And that's a call that you make anyway. It's not us, right?
That's already in the public health order as well. So once we get to either low or moderate transmission, so that would be anywhere under 50 per cases per 100,000 over a 7-day period for incidence rate. The masking requirement just becomes a recommendation.
Okay, great. Thank you. I just wanted to point out also that I think 3 of our Pickens County commissioners have been sick, including me last week. I tested negative, but we've had 2 test positive. So this is pretty much working its way through the community. And at least one of them said that she did not understand how she possibly, could have gotten it. She's masked and vaccinated and cautious, and bam, still got her. So it's ubiquitous and it's insidious and it's coming for us. With that in mind, enjoy the rest of your afternoon. And I think we're steady as she goes for now. Thank you, Jordana, and thank you all for coming. Patty, did you have a final comment? It looked like you might have been wanting to say something.
No, I'm good. I'm trying to print out my information for my next meeting that starts here in about a half an hour. So
Got it.
Good job.
I want to tell everybody, Patty is our new board chair for the Pickens County Commissioners for the next year. So if you have any questions or complaints or big issues, just call her. I'll share her personal phone number and you'll all be covered.
Thanks, Rick. And I was considering not continuing as the alternate for the Board of Health, but I chose to stay on because I think this is a group worthy of time and attention.
And she loves the idle chat.
I love picking on Greg being a chair.
Everybody's sitting on their hands today. That's fine with me because we're still 10 minutes ahead. Why don't we end this 10 minutes early?
And Greg,
I'm looking for a motion.
Motion. Thank you.
Oh, I think I already had a motion, right? Or did you ask me for one? Krista and Dr. Kurt, I'm going to pick you two. All in favor, raise your right hand and be healthy and safe. And we'll see you again soon. Thank you.
All right. Thanks, Greg.
We're adjourned.